Hello, this is Dr. Brian Calhoun from Anesthesia, and I want to talk to you today about epidural analgesia. We've had epidurals in OB for about a year and a half, and it has given good relief to a bunch of laboring women. And so now I think it'd be a good time to have it available on the floor for patients who've had abdominal surgery or who have rib fractures or some orthopedic injury and surgery patients. So I'd like to start off by telling you about the anatomy and physiology and the pharmacology of the drugs that we use and how it works, the anatomy of it, and then go on to what can happen, what can go wrong, and the complications and how we need to work together as a team to prevent those complications. So the first bit of information is about the anatomy, and this slide shows the spine and the lumbar portion of the spine, the lower back. And you can see in the top there that the spinal cord is not just one thick structure, but it's a bunch of nerves. It's called the cauda equina. And the reason we like to put the needle in at this area of the back is because when the needle, if the needle goes through the dural sac into the cerebral spinal fluid with all those little nerves, that it won't damage the nerves as readily as if it was one big structure, one big thick structure, and solid like it is in the thoracic and cervical region. So that's why we put the needle in at L3-4 between the third and fourth lumbar vertebrae. If you look at the spinal anatomy there, you can see the spinous process. That's the bumps you feel on the patient's back. And that in between those spinous processes is the interlaminar foramen. So that's the hole that we put the needle between the bones, and then the needle gets into the ligamentum flavum that you can see there. And when you have the needle in the ligamentum flavum and you try to inject fluid, there's resistance. You can't inject because the tip of the needle is surrounded by dense fibrous material. But then when you pop through the other side of the ligamentum flavum into the epidural space, there's no resistance to injection, and you get a sudden loss of resistance. As you're pushing on the syringe, as you advance the needle, all of a sudden it pushes easily, and that loss of resistance shows you that you're in the epidural space rather than the ligamentum flavum. So that's where you want to be. So then you thread a hollow catheter through the needle into that epidural space and take the needle out. You can see that that epidural space has veins and fat in it, and we'll come back to talking about that sometimes those veins can get you in trouble because you can put the catheter right into a vein. If you push the needle too far, you can see that you're only 2 to 5 millimeters from the dural sac, and if you pop through the dural sac into the cerebral spinal fluid and you put local in there, it's much more potent and makes the patient a lot more numb if you put local anesthetic into the cerebral spinal fluid than if you have it in the epidural space. So in this next slide, just spinous processes going off to the right, the intervertebral foramen where the nerve roots come out to the sides, and the ligamentum flavum is there, and you can see where as you put the needle between the spinous processes that you have to go through the ligaments from between the spinous processes and then through the ligamentum flavum into the epidural space. This next slide shows the spinal cord with the different layers, the dura mater, the arachnoid, and the pia, and then the spinal nerves coming off. Note the end of the spinal cord at L2 and the cauda equina extending down from there. In this next slide, you can see the spinal cord with the dura in yellow, the dural covering, and the the nerve roots coming off of the spinal cord. And then the double arrows there show the epidural space where you'll put the local. And then it kind of follows the red arrows around. And what it does is right at it's called dural cuff sleeves, where the dura wraps around the nerve roots. The local anesthetic can diffuse across that dura there and uh, go in and affect the nerve roots and then affect the spinal cord as well. And on the picture on the upper right, you can see where there's evaginations of the dural cuff sleeve where they go through the dura. The cerebral spinal fluid can go through the dura and provide a lot of surface area for the local anesthetic to diffuse across into the cerebral spinal fluid and then into the um, spinal cord and the nerve roots. So from there, the local anesthetic can block the sodium channels in the spinal cord and the nerve roots, and that is basically blocking the transmission, like blocking an electrical transmission line, blocks that from happening so that the sensation of pain doesn't make it all the way to the brain. And also with narcotics, the narcotics can get into the spinal cord and to the nerve roots and attach to the mu receptors for the opiates, and that will also decrease the transmission of nerve transmissions up to the brain. This is another picture just to remind us that there's a blood supply to the spinal cord. Most of the time, if patients are not anticoagulated, if you happen to get a needle through or into one of these arteries, then it will clot off. But you always have to remember that there are a lot of anticoagulants being given to patients these days, and we need to be careful in how we place the needle, and then we will be asking you to be our eyes and ears to let us know if any patient has a change in lower extremity sensation or motor ability, because that would be the indication that one of these arteries had enough of a bleed that it was pushing on the spinal cord and decreasing the function of the spinal cord. And this is a dermatomal map, and the kind of the things that we keep in mind are T10 are the T10 is the level of the umbilicus, L3 to the knee, and T4 to the nipple line, and then C8 to the little finger. So what we want with most general surgery patients is about a T6 to T8 level. So it will cover their skin incision in the area of surgery. But if you go up to T4, not only do the patients have a little bit of anxiety because they can't feel themselves breathe, but also at that level, there's more of a chance that the numbing medicine will numb up the sympathetic nerves enough that the heart rate might be affected and the heart rate might go down, as well as the blood pressure. So we've talked a little bit about the complications with the dural puncture. That would be when the needle goes a little too far through that dural membrane and into the cerebral spinal fluid. And like I mentioned, if enough numbing medicine gets in there, they will get a spinal, a true spinal, and that is a lot denser numbness than an epidural usually produces, and they won't be able to move their legs, and they might have more pronounced blood pressure decreases. If we just poke through the dura with the needle, but then don't end up putting a catheter in it, then there's overall of a spinal headache. Um, and so that's from the cerebral spinal fluid leaking out of that hole in the dura, and then the brain kind of sags down. The meninges that attach the brain to the cranium are the pain sensitive part, and so that's why they get such a bad headache. So that's one complication that can occur from putting in the epidural. Usually, we know when we have put the needle through the dura, and because cerebral spinal fluid comes out pretty fast out of the needle. But if the patient has a headache, we always want to know about it, and so that's one of the things we'll ask you to let us know about. I also pointed out the epidural veins, and then and if the epidural catheter gets into one of those veins and we don't realize it, well, we usually aspirate for blood to see if blood comes out of the catheter, and if it does, then we replace the catheter in a different spot. But if we don't realize it, we give a test dose of 5 cc's of a local anesthetic with epinephrine in it, and we look for the heart rate to go up. And if it does, that means that the epinephrine has gotten into the vascular system, and that shows us that the epidural is in a vein. So we test that. If enough numbing medicine gets into the systemic circulation, then patients can have tingling around their lips or ringing in their ears. And if we don't stop it at that point, they can have a generalized seizure or trouble with their heart. So that's always something we're alert to, and that should not happen to you because um, we're giving such dilute solutions of local anesthetic that the number of milligrams that they get in any 1 hour or time period is usually not enough to cause a seizure or trouble with their heart. But that is a complication that we're alert to. When the when the epidural catheter goes into the epidural space, there is a particular distribution of the fluid, and there can be a membrane in the center of the epidural space that doesn't allow the fluid to go to the other side. It can be like a midline membrane, and so the fluid sometimes does not provide equal analgesia on both sides. And usually what we do in that case is pull the catheter back and give a bolus of more concentrated local anesthetic to see if we can kind of get around that membrane. So one of the things you do need to be careful about is if the patient says, yes, there's just one like dinner plate size area that hurts on my left side, well, then that's something, again, that we would like to know about, and we need to come and pull back the catheter a little bit and give some more concentrated local anesthetic. I touched on the epidural hematoma, that the needle can cause enough of a bleed that the resulting hematoma can push on the spinal cord enough to cause lower extremity weakness or numbness. And it doesn't always have to involve back pain, but it sometimes does. And so we'll just be asking you to do checks of their lower extremities to see if there's increasing weakness or numbness, and let us know if there is, because even though it's a very rare complication, we need to be alert for that epidural hematoma. Those patients require surgery within a 24 to 48 hour window to preserve that nerve function, because otherwise the nerves are just left incapacitated. With the local anesthetic numbing up the patient, the very small fibers that are the first to be numbed up are the sympathetic nervous fibers. And so that causes vasodilation, because one of the things the sympathetic nerves do is to provide vasodilation or vasoconstriction. And when you block those nerves, vasodilation occurs. So there's basically more room in the vascular system. Then you have blood, and the blood pools in the dependent areas, and you get hypotension or a lowering of the blood pressure. We usually give a bolus of fluid when we put the epidural in, and so hopefully you will be spared a lot of hypotension. But if we come to the floor to give a bolus because of inadequate pain relief, then we'll be asking you to take blood pressures often for, for 20, 25 minutes to make sure that hypotension doesn't occur. The one of the complications of the narcotics and the mu receptor agonist is respiratory depression. So I know you've seen pruritus, the itching, and nausea and vomiting from intrathecal narcotics, and those same symptoms can occur from the epidural narcotics, although usually not as readily because it takes more of a milligram dose of mu agonists to cause those symptoms in patients. We will be asking you to have the patient on a pulse oximeter and record respiratory rate just so we can keep track of the respiratory depression. So the way that we would operationally accomplish this epidural service on the floor is that the patient would come out of surgery and go to the PACU. We would have the epidural in place at that time. We would hook the patient up, or the PACU nurses would hook the patient up to the epidural pump and instruct the patient, if they're awake enough, how to push the button to give themselves extra doses at that time. And then we would observe the patient until they're stable with their blood pressure and see if any complications occur, and then bring the patient to the floor. Once the patient gets to the floor, we will be asking you to be our eyes and ears to see if the epidural is working correctly and to see if there's any complications from using an epidural. The first question that needs to be answered is the epidural working? And so you can do that by asking the patient the pain score, and ask not only the pain score, but every time you use the pain score, if you can ask, okay, is that, if it's a 4, is that 4 bearable? Are you suffering with that 4? Can you sleep, and can you deep breathe? And so it gives that number kind of a context besides just oh, we have to treat every 4 or every 5. So ask the patient what their pain score is, and if the pain is a lot worse, then it could be that the patient's just gone for a walk, or it could be that the epidural stopped working. So you can look on the patient's back and get some information. The tip of the catheter is disappearing underneath the skin, right underneath a transparent dressing, so you can see where the catheter is. If it's pulled out completely and you can see the tip, then you know why it's not working. If there is a puddle of local anesthetic underneath the tegaderm, then that's a pretty good indication that's why it's not working. Another thing to look for is if there's redness around the catheter site as it disappears into the skin. If it's red in an area bigger than a pencil eraser, then we should probably know about it. And if there is some pus coming out of it, then we should probably know about it as well. So there are marks on the catheter, and we will tell you what mark is at the skin when we put the epidural in, so that if the marks are any different, if it's a lot shallower and the patient has pain, then that's a pretty good indication that the epidural pulled out, and that's why the patient has pain. If the marks are within 1 or 2 centimeters of where we said they were, then probably no need for worry. uh, especially if the epidural is working. So the patient could potentially have hypotension, like we talked about, and if so, then give us a call, and we'll probably recommend a fluid bolus and put them in Trendelenburg if it's a mean below 55 or 30% different than what they came in with. The narcotic in the mixture, which is typically 1/8% bupivacaine with 5 mics per cc of fentanyl, uh, and it can go down to 1/10% bupivacaine plus 5 mics per cc of fentanyl. The narcotics, the fentanyl, is very lipophilic. It goes through the membranes very easily and gets into the cerebral spinal fluid, which can then get to the brain and cause respiratory depression. There's very little fentanyl in with the local anesthetic on a relative scale, so that the chances of respiratory depression are low. But nonetheless, we do need to keep track of it so that patients who are very sensitive to narcotics don't get excessive respiratory depression. For pruritus or nausea and vomiting due to the narcotics, we can decrease the rate and treat that. There's a possibility of urinary retention, but most of the patients we use epidurals in already have a Foley catheter, so it's not an issue. This is a little introduction into epidural analgesia, and there is a handout to go along with this, which you can either use the paper handout, or I can give you the web address where you can read it online, and we're going to try to get it so that you can get 5 hours of CME uh, by reading that, and that will set you up with a good introductory knowledge into epidurals. And we are going to get the pumps, and we'll educate you on the pumps so that you'll know how to clear them and check for the total amount infused per shift, and use them appropriately. Thanks for your attention. I appreciate it.